Hello everyone, my name is Sarah Turle. I'm a 13-year survivor of breast cancer and also recently diagnosed with a standalone incurable lung cancer. In 2020, my husband was diagnosed with mouth cancer, thankfully currently believed to be cancer-free. I am incredibly proud to be a patient partner where over the last 9 years, working together with staff, originally with the London Trust, who saved my life, and now with Kent and Medway Cancer Alliance and NHS England Cancer Patient and Public Voice Forum. I've been involved in a lot of processes and initiatives that hopefully bring improvement of experience to patients. I am delighted to be with you all today with the 2022 Picker Cancer Patient Experience results and to tell you a bit about my experience over the last 13 years living beyond cancer and also the last few months where I am now living with the knowledge that I am dying with cancer. With the prognosis of 18 months to a few years, really hoping that the immunotherapy I am gratefully receiving will hold back the tide for those few years and who knows, hopefully more. So I have got just a wee bit of experience of cancer. My aggressive breast cancer saw me receiving everything bar the kitchen sink of treatments, but end of 2014, 4.5 years after diagnosis, with 3 new scares ruled out, but a combination of a highly pressured work environment and a number of debilitating side effects of mild cognitive impairment, increasingly impacting on my ability to do my job and with that my well-being, I very sadly gave up my career, a lifetime of working from 17 and my much loved job in education. Couldn't risk doing this today without my personal auto cue. So what does patient experience mean to me? It means that I see myself as an equal partner in my own healthcare. Do with me, not to me, together. And what do I ask of you, my health practitioners? I ask that you treat me with the respect I will treat you with. I want your ears as much as your voice. I want your skill, knowledge, professionalism, and kindness. I ask for straight talk and honesty. If you think or know something, I want to know too, and I will greatly appreciate and work together with you for it. It also means recognising patients as health experts too, and believing that best outcomes in anything to do with healthcare can only happen when we work together in partnership, involved from the outset. Not you and us, but we together. So what do I see as to what has brought the biggest impact to my own patient experience? Skill, expertise, of course, hugely important, but no bigger impact than a simple initial greeting. Hello, my name is. A greeting with a smile, a first impression, the start of a relationship and the beginning of a partnership. Tell me who you are, what your role is and what you're aiming to do. Involve me. Experiencing for myself, but also seeing as I have time and time again, the impact it has on patients whose anxiety can lighten within seconds of this greeting. And always event, in my opinion, a lost opportunity when it doesn't happen. And don't just say it, wear it on your name badge, and please don't rely on your lanyard for communicating this where it is generally swung wrong way round, normally at groin level, a bit awkward when you're trying to read it at that level, but clearly on a badge, identifying you and your role. Please wear your nurse in charge armbands when able to, and how I'd love to see names and roles on all theatre caps too. And this isn't fluffy stuff, because what I've learned is how much impact it has on me, other patients and families. The hugely important personal touch, yes, but knowing staff members' name and role is the start of continuity of care, where I am the only one constant when seeing many different staff in many different departments and across many organisations. For me to refer by name and role from one member of the staff to another when involved in multiple appointments and through treatment has proved very helpful to staff, and that of course helps me. And as we all know, continuity of communication and care can and is a significant challenge. It can also increase safety as another catch point in the Swiss cheese model of multiple layers. And when that greeting is missing, everything can change. I felt totally yucky, like a piece of conveyor belt processed sliced meat. Ashamed even, that I had accepted a member of staff who had not introduced themselves, department name on worktop obscured by a cardigan, no name badge visible or lanyard, with minimal words spoken, holding my bare breasts. Since that day, I model what I expect if it doesn't happen by replying when being asked for or checking my name. Yes, hello, I'm Sarah Turle, and who are you and what do you do? It nearly always prompts a friendly, informative response, and that's all I want. Only once did someone say, quite seriously, why? Are you going to complain about me? People often say to me, how come, Sarah, you always have a good experience? And you know what? Of course I don't always have a good experience, but I work at making it as good an experience as possible, with collywobbles in my stomach at times, when I ask for something that may be off script or question the status quo. Right to do, but far, far from easy at times. Do I want the very best of absolutely everything? Yes, of course I do. But I also appreciate very much indeed the hardworking people, the humans who I want to deliver this care. And I also recognise the increasing pressures healthcare are working under. I treat staff as I want to be treated, and I reap the benefits of that. I am more than ever aware to the pressures on the NHS through COVID and beyond, and where we can, if able, we do need to do all we can to work together. No easy feat when, as patients, from the minute we enter a hospital environment, we regress. We regress back to a parent-child relationship, waiting to be told, directed, our senses numbed to time, and the communicative, capable people we function as in our regular lives lost, losing the ability to question and speak up. But this can change. As patients, we need to be able to speak up and do this with a voice that is encouraged and welcomed, a true partner in care, working together with staff for the best, safest experience with best outcomes, and not seen as an adversary to be feared. Whilst these patient experience questionnaires can absolutely brilliantly really highlight what is going well and also really pinpoint what needs to improve, we have to be mindful of the messaging that can go out that can impact on patients and staff. Back in October 2014, The results of this questionnaire, then run by McMillan, came out, and my local newspaper ran a large banner headline saying that the trust that had treated me was in the bottom 10 for worst cancer patient experience. If I had been due to start treatment there, it would have caused me the hugest anxiety. Plus, this wasn't my experience. I had received overall brilliant care. When I deep dived into the questions, yes, there were areas that were scored low and there was definitely room for improvement, but absolutely nothing that warranted a fear for being treated there. So I contacted the paper, as you do, and was given the opportunity to respond via an article and linked film of me talking. The only part of it I would disagree with now, and I really feel shameful saying it, is that I use the fatal words of that it's just the way things are. And I've spent the last 8-9 years working hard to prove that is not the case. Nothing should be just the way things are. The beginnings of my patient partnership right there. The next 7 years saw me involved in so much. The making of 2 cancer support films for patients, quality improvement initiatives, patient safety work, to mention a few things. But at the core has been being out in patient areas, speaking with and listening to patients, relatives, and staff, experiencing what they were experiencing and using what I learned to help me in my work with staff improving experience. And so to March of this year, and my, yes, devastating, incurable standalone lung cancer. I am absolutely, more so than ever, putting into practice everything I believe in and speak about. And yes, whilst initially staff have been a little taken aback by my upfront saying that I want to be totally involved, do you know, they all immediately get on board with it because they absolutely see the benefits when I speak about them. To carry my file of reports, notes from appointments, etc. with me, and being able to relay conversations because I have made sure I have understood at every stage what is happening to me. Having asked for simpler explanations when needed is because I recognise how busy staff are and how many patients staff see, coupled with time pressures. I want to help and I can help, and that has always involved speaking up when things could, should, or need to be better. On a not so long ago hospital stay, an unexpected, potentially derailing issue was identified with investigation following. All fine to proceed, but I asked to be told why decision had been made, that all was fine, not just assuming it was fine as an additional point of safety before we proceeded. I also asked for a printed copy of the report, just in case I needed it in the future. Staff responded brilliantly to both requests, whilst clearly not regular requests for them. And hey, that same issue did indeed come up in discussions literally a few weeks later, re my treatment plan. To be able to pull the requested report out of my file was greatly helpful for the doctor I was seeing, who had a read and confirmed all fine to proceed. Again, well received and appreciated by the doctor, who also commented on what a well-informed, prepared patient I was. I loved that. Together with my file in hand, Lung Cancer 2023. Having this information, though, potentially kept my treatment plan on time track. The care I am receiving is overall superb, balancing, unnerving, treading water in limbo land, with the very real pressures on our services. I have now experienced recent care in a number of towns, cities and hospitals, and I have seen and heard the incredible challenges staff are facing. I feel I've been talking about the incredible challenges for the last 8 years, but you know, believe me, you know, I really do get it. I have never seen such tough times. Patient experience can't happen without staff experience. Patient safety certainly can't happen without staff safety. We are all in this together, which is why I believe we need to support and work together for the very, very best outcomes and experience for all of us. This has served me very well indeed. Thank you.
So I'm Jodie Moffat, and I am Deputy Director for Policy and Strategy in the Cancer Programme at NHS England, and I'm delighted to be joining with you this morning just to give you a bit of a feel for how important experience of care is for us as a programme, how we work with CPARES and some of the real-world examples of how we're taking forward work in this area. So just on to the next slide if we can. Thank you, AJ. Just in terms of making sure that we're starting off with a shared view of what experience of care is and how important it is. So on that first slide, we had a look at some National Quality Board infographics, which just really highlight. I don't know if you can go back, AJ, sorry, or if it's just me that's seeing a slide. That's the one. Thank you so much. That really just reinforces how important experience of care is to high quality delivery for patients, and that it's on an equal footing alongside clinical effectiveness and safety. And that taking an interest in experience of care and seeking to make continuous improvements in experience of care for patients isn't just a nice thing to do, but is actually a legal requirement and something that we do have to do as well. And when we're doing it, there's lots of advice out there about what we need to consider to do it properly and to plan for services which deliver the best experience of care possible for patients. And there are 3 key principles which form part of that. That includes making sure that we have experience of care as at the core of our priority programmes, that we are having co-production as the default and working together, and we very much heard that theme within Sarah's presentation, and that we are using insight and feedback and using that to inform where we focus and also to assess whether we might be making any change and actually leading to that improvement in experience of care for patients. And in cancer, experience of care is important from the very first suspicion of cancer, that very first moment of diagnosis, all the way through. And again, we've heard from Sarah that there are many different directions that someone's experience of cancer can take, and experience is going to be absolutely vitally important throughout all of those, and we have to be ready to ensure that we're doing what we can to make sure that experience is optimized at all of those points. Okay, next slide. Thank you, AJ. So I think on the next slide, what we were talking about there was about the priorities within the NHS Cancer Programme, where we do absolutely want to achieve an improvement in experience of care and quality of life for cancer patients. We also want to very much deliver on those ambitions within the long-term plan around early diagnosis and survival, to reduce inequalities and to improve operational performance and length of pathways for patients.
Jodie, sorry to interrupt, just to say that AJ's lost connection on the call, so we're just catching up with the slide deck.
No worries. Okay, so the map on the right-hand side, which I'm sure many of you will be very familiar with, is the map of the Cancer Alliances that are the primary delivery vehicle for achieving those long-term plan ambitions around cancer and for achieving those shifts and improvements in operational performance. And it's very much about working together as a community to do that. And those cancer alliances work very closely with their stakeholders locally and the regions in order to deliver on that locally. Okay, I'm going to go to the next slide now. So we touched on earlier how important insight and feedback is as a key principle within achieving best experience of care services. And there are a whole range of different sources of feedback, and they come together as a puzzle. Today, of course, the focus is the Cancer Patient Experience Survey, which NHS England has been running since 2010 and is delivered by PICA. The Cancer Patient Experience Survey, because of its scale, the numbers of people who are invited, gives us a really important national view of experience of care. And in that sample size, we're able to look at a lot of variation, understanding inequalities, but it's also there at local level, split down by systems and cancer alliances and providers to be able to really understand that feedback from patients and to be part of that jigsaw puzzle of insight and feedback that they can use and draw on when seeking to make improvements for patients with cancer. Okay, next slide. And how do we use it as a team? Well, we use Cancer Patient Experience Survey results to inform where we focus our attention. And we use them to underpin our Cancer Experience of Care improvement collaboratives, which bring together a range of cancer health professionals and people with lived experience of cancer in quality improvement methodology to drive improvements for people with cancer. So very much picking up on that principle of co-production and again, that principle that Sarah mentioned of working together. And they use, as you can see, this quality improvement methodology to inform and improve what they are offering. And just to bring it a little bit up to date with the next slide, please, AJ. One of the things that we have seen within CPERS is that people who have a pre-existing condition tend to report a lower overall experience of care than people without a pre-existing condition. And so in light of that, we are focusing our next 5th cohort of the Cancer Experience of Care Improvement Collaborative on working with projects and healthcare professionals and lived experience partners to drive improvements in experience of care for people with mental health, learning disability and autism, dementia, and indeed any pre-existing condition. And applications for that, our 5th cohort, have recently closed, and we're really excited to be working with a number of projects over the coming year up until next spring in this quality improvement methodology, which provides some structure and time out to really consider what it is that people want to improve, really step back and not make any assumptions and use data and insight to inform the direction they take, working closely, of course, with patients in co-production. One of the things that we hear from the KIC is it's a real opportunity to identify and champion good practice. And we also see that through this next slide, which focuses on our Cancer Experience of Care Award, which is one of the awards in partnership with the Patient Experience Network and co-sponsored with McMillan so that it's free to enter. And in fact, this award used to be called the CPERS Award because it was based trying to identify projects that had used CPERS as their basis. But actually, as I've spoken to earlier, there are a range of different sources of patient experience and feedback available to teams that they can use to be driving progress locally. This photograph here includes members of our National Cancer Programme who were visiting the Royal Free, who won the 2022 awards and had used CPERS as a key baseline for their work. And you'll be able to hear directly from Azmina and Kerry themselves about the inspiring project that they were leading and involved with at the Royal Free. That there's lots happening out there on experience of cancer. And I'm absolutely thankful to everybody out there who has played such a part in that work and will continue to do so. We have a huge opportunity to improve experience of cancer care. The Cancer Patient Experience Survey does show that overall cancer patients do have a very positive overall experience of care, and we'll be hearing more on that later. But CPERS shines a light on those things that we could improve and should improve. And we are delighted, as I say, to be working with you all in taking that forward.
I'm Caroline Hancock. I'm a research associate on the team working on the National Cancer Patient Experience Survey at PICA, and I'll be taking you through some of the key areas of the CPERS 2022 quantitative findings. So to some of the key sources of data that are available, so there's a full set of reports for the 2022 results at a national, alliance, ICB and trust level on the CPES website. So there's also an easy read version of the national report available again this year. There's also a free text workbook, so the free text responses from patients. These have each been sent to each individual trust for you to review. Then what we have new for this year is that we've now added an infographic, and we've also developed a new interactive tool. So as some of you may have seen, we launched a new website for CPES earlier this year. And just if you want to find the results, you can go to the results tab, and then you can go to either the national or local results and find the reports that you need. And we've also developed a new interactive dashboard. So the dashboard can be used to look at all levels of results broken down or filtered into a number of different ways, as you can kind of see here. So people can spend some time here and explore the results at their own pace. So the chart that you can see usually has a table underneath as well, just couldn't fit it on the slide. And it has all the information in it, and you can download these in a variety of different formats and use them as you choose. So we really do encourage people to go and spend some time and use the interactive dashboard. And then new for this year is the nice new fun infographic that we have, which is a visual display of some of the headline findings. Then something we have coming soon is a response rate analysis. So this will be provided at both the national and trust level, and we'll have data on their response rates from different population groups to understand how well the responses reflect the makeup of the eligible population. So just to kind of get a better understanding of whose voices are potentially being missed. Then something else new that we have for 2022 is going to be trend data. So like Jodie mentioned, the survey was reviewed in 2021. So prior to this, the survey hadn't actually been changed since 2015. And so we changed it, in 2021. The changes were overseen by the advisory group, and the new questionnaire now reflects the significant changes that have happened in service delivery, clinical practice, and policy. So as this is now the second year of results from the new survey, we now have year-on-year comparisons included in this year's reporting. Then we also have subgroup comparisons. So comparing the overall experience by subgroup allows us to explore the differences in how people experience their cancer care. So we won't be talking about that too much in this presentation, but it is wanting to let you know that it is there for people to explore. So experiences will likely vary between demographic groups. So looking at health inequalities across cancer care locally is important to take into account when developing improvement plans. So the following kind of subgroup comparisons are available to explore either by looking at the national report or by looking at the data tables, data Excel tables, or the interactive dashboards. These are all available on the website. So now just to move on to just eligibility and who we actually heard from in the survey. So firstly, who is eligible? So all NHS trusts in England providing acute and specialist cancer care are asked to provide a patient sample. So this includes all patients 16 years and over with a primary diagnosis of cancer who were admitted as an inpatient or day case patient for cancer-related treatment. And the survey sample period was between the 1st of April to the 30th of June 2022. So for 2022, we had a response rate of 53%, which is really good. Then just looking at a breakdown of the respondents by different demographics, we could see that there were more females responded this year than males. And in terms of age, the majority of respondents were between the ages of 55 and 84. This is very similar to what we saw last year. Then also just looking at the number of responses by long-term condition. So there's a question that asks people about the long-term conditions. It's a multiple choice question and just kind of illustrates that many people live with different long-term conditions while going through their cancer care. So we're now going to take a look at the questions that had the largest positive change and the largest negative change compared to the 2021 results. So the 5 scores with the largest negative change. So apart from question 7, the questions are linked to support, communication, and information. So fewer patients reported that they could get help from staff when they needed, or being able to discuss their worries or fears. There were also fewer patients reporting that they had confidence in the team looking after them. But on a more positive note, the scores with the largest positive changes related to questions about involvement of family and friends. So more patients reported being able to have a family member or friend with them when they were told about their diagnosis, as well as when looking at treatment options, as well as family being given all the information they needed to care for the patient when at home. So next up, we're going to look at the headline findings. So there's going to be 1 question per section that we've selected to provide an overview of experience across the cancer care journey. So we'll touch on a few of those here, and then these sections will be covered in a bit more detail in the following slides. So to start off with overall experience, respondents were asked to rate their overall experience of care from 0 to 10, with 0 being very poor to 10 being very good. The average rating for 2022 was 8.88, which is slightly down from 8.91 the previous year. And then the chart on the right shows the distribution of responses, with the majority of responses at the higher, more positive end of the scale. So diagnostic tests and finding out that you had cancer. So there were both positive results and areas for improvement in people's experiences of finding out that they had cancer. So just over 3/4 of all respondents said that when first told that they had cancer, they had been given the option of having a family member, carer, or friend with them, as we mentioned earlier. And when patients were asked how they felt about the way that they were told that they had cancer, 74% said that they were told sensitively, and 85% said that they were definitely told about their diagnosis in a place that was appropriate for them. Also had 76% of respondents said that their cancer diagnosis was explained in a way that they could completely understand, and 84% said that they were told that they could go back later for more information about their diagnosis once they'd had time to reflect on what it meant. Support from your main contact person and care planning. So looking at support from a main contact person, 9 out of 10 respondents said that they had a main contact person within the team looking after them who would support them through treatment. And 84% of respondents found it very or quite easy to contact their main contact person, with 95% of respondents said that they found the advice from their main contact person to be very or quite helpful. And looking at care planning, so when asked questions about how they were supported during their cancer care planning, 71% of respondents said that before their treatment, they definitely had a discussion with a member of the team about their concerns and needs. And of those who had this discussion, 93% said a member of the care team helped them create a care plan to address these concerns. And then 99% of respondents who had a care plan responded positively, saying that a member of the team looking after them reviewed the plan with them to make sure that it continued to reflect their needs or concerns during treatment. Hospital care and care from your GP practice. So looking at people's experience of hospital care, people treated for cancer in England reported generally positive experiences of care in hospital, according to the 2022 results, with 88% of respondents saying that they were always treated with respect and dignity while in hospital, and 84% of respondents saying hospital staff did all that they could to help the patient control pain. And when asked about receiving clear written information about what they should or should not do after leaving the hospital, 88% of respondents said that they received clear information that was easy to understand. And 78% of respondents who had been treated as a day case or outpatient said that they were always able to talk to hospital staff about their worries or fears if they needed to. However, some areas of hospital care had a lower experience rating by respondents. So personalization and person-centered care, which are policy priorities and important to patients and users, were lacking in some places. For example, only 70% of respondents said that they were always involved in decisions about their care and treatment while in hospital. So this means that 70% of respondents felt that they were not involved as much as they wanted to be. And with only 6 out of 10 respondents who stayed overnight, saying family or someone else close to them were definitely able to talk to someone on the team looking after them. And then 64% of respondents answering that during their stay in hospital, they could always talk to hospital staff about their worries or fears if they needed to. So this is slightly down from 67% in 2021. Then care from your GP practice. As mentioned earlier by Jodie, it's another area of response that showed a lower level of patient satisfaction. Was outside the hospital in care from your GP practice. So of those that said their GP practice was involved in their cancer treatment, 45% said that they got the right amount of support from staff at their GP practice while they were having cancer treatment. And only 21% of all respondents said they had a review of their cancer care by a member of staff at their GP practice. And then living with and beyond cancer. So respondents were asked whether once their cancer treatment had finished, could they get emotional support at home from community or voluntary services. 31% of respondents said they needed care and support, said that this was definitely the case, while 78% said that they were given enough information about the possibility of the cancer coming back or spreading, such as what to look out for and what to do if they had any concerns. So that concludes my overview of some of the national findings from the CPES 2022 results. If you want to explore the results in further or in more detail, please take a look at the different sources that we have available on the website that I mentioned earlier. And if you would like any further guidance on how we do scoring or suppression or how to use the reports, please refer to the technical document on the CPES website. I think we can open up the floor if anyone has any questions.
Yes, so Winnie's just asked a question about when the response rate analysis is due to come out. I understand that we're aiming to get it out by end of August, early September for that. Once it's out, we'll be popping around an e-bulletin, kind of sharing it with you all. And you kind of have, we did the same analysis last year, so you should have that on file as well from last year that you can have a look at in the meantime. Annie's asked what's happening with the qualitative data. So Caroline mentioned that we've shared free text workbooks with every participating NHS trust. So that's a workbook which contains all free text comments for your trust, which have been looked at by kind of topics that are coming out of the data, but also you can have a look at free text comments by things like tumour group, age, ethnicity, that type of thing. We haven't run a national qualitative analysis this year, partly because actually we think that the analysis run last year still stands and we wouldn't expect to see much movement in the types of things coming out of the data. But there's further kind of qualitative work planned by NHS England into kind of specific themes and topics. So that's something just to look out for in the future as well.
Thank you, Jenny. Just alert everyone to comment made by Claire Marshall in the chat as well, which was yesterday I heard from a person newly diagnosed with cancer that the invitation letter she received for her appointment still explicitly says not to bring someone with them to the appointment. She knew she was highly likely to get a diagnosis, so ignored the letter and took someone. And Claire has suggested, I wonder if everyone on the call today took an action to check what info is still going out to people from your services. We could make such a difference to people's experiences. That's a really great point, a very powerful one. But has anybody got some questions they would like to ask in person by voice or video as well? as using the chat? If so, please put your hand up and we'll unmute you. Get to you, Lee. I can see you there. So Lee.
Hi, hopefully you can hear me. Maybe you might be able to see me in a second. I just wondered specifically question 52. We've got a really low positivity score on that for all of our patients. And I'm not a cancer nurse, I'm a patient experience nurse at our hospital. But what I understand is that the reviews with the GPs actually happen within a set period of time after the treatment, and therefore it might be that the patients just haven't travelled that bit of the journey yet, and that's why the positivity rate was low. And I wondered if you'd noticed that nationally, and if there was something we could do about the question in terms of the timing.
Sorry, I missed who asked that question as I was busy looking at the questionnaire, trying to get the right question up for people to see in the chat. When you thank you for waving. When you say about timing, is that how we reference the care planning in terms of kind of post-treatment, living with beyond cancer, that type of framing?
Yeah, I think so. So I think the question is, patient has had a review of cancer care by GP practice, and overall we had a 21% positivity score for that question, which is obviously really low. But if we looked at our patients that were, because this is patients that have been an inpatient for treatment, we felt that maybe the point at which they were asked the question, they just hadn't had that appointment yet with their GP because it was just not there on the pathway yet, if that makes sense.
Yeah, I think there are two things here. I think you're right. I think it's because we obviously sample from April, May and June, we're picking up people at a specific point of their kind of journey. So when the questionnaires go out, it's in the kind of autumn winter stage. So you might expect that many people have either are still in their treatment pathway or just finishing that, so may not have had that kind of post GP care. And then there's probably something about us taking a note to look again at the wording. I know when we went through the questionnaire development, there was a lot of kind of time and effort from the advisory group and other stakeholders put into figuring out how we can ask patients about care planning in a way that they understand. But it's a point that we'll take away and can discuss with NHS England and the advisory group.
Perfect. I can see that Leslie Smith, she's articulated the time frame for me that I wasn't able to do. So it's the 12-month review. So perhaps the question should be something like, if it applies to you, have you had a 12-month review with your GP? Because it's a great question and we should be asking it and we should know. But the score being so low actually isn't helpful if our clinicians are coming back to us saying, well, that doesn't apply to most of my patients. Then I can't actually articulate to them when it is and isn't working, which is the whole point, isn't it, of the questionnaire. But yes, thank you.
Thank you.
And we have a question from Sean Dennison as well. So go ahead, Sean, you may be on mute.
Apologies. Yeah, I put a question on the dashboard just about on the chat about whether the dashboard will be able to compare tumour sites with last year's results or with the national. The last time I looked at it, I could get the tumour site results up, but it didn't compare it with anything.
Yeah, if you're on the national view, you can look at tumour group or cancer type for each of the scored questions, and that's for 2021 and 2022. For Alliance, ICB and Trust, we've just got it for 2022 currently, but we are going to release the trend in there as well, so you can see that. I know there's another question in there about our use of unadjusted and adjusted scores, which is a bit more of a technical question around, can you compare between, I think it was between NHS hospitals or sites within a trust, can you compare scores because they're unadjusted rather than adjusted? And so if you're not familiar with CPES, we use adjusted scores. Oh, could someone go on mute, please? Sorry, I get a bit of feedback there. Yeah, we use two different types of scores. Adjusted scores are when we ask people to make external comparisons. Unadjusted scores are when we ask you just to look at your own local results. And we don't do any of that adjustment at lower levels, mainly because the adjustment model uses those subgroups in it. So when we carry out, the technical term is case mix adjustment, we use things like tumour group, IMD, ethnicity, etc. as part of that model. So that means we can't take a similar approach at a lower level that includes those subgroups. It's a bit of a technical response to an answer. So if there's something else anyone wants to discuss in relation to that, then kind of ping the CPES email and we can take that way and talk about it a little bit more. Sorry, AJ, I noticed there was one other comment in the chat about whether there's any Cancer Alliance level qualitative analysis coming out in the future. I'm not aware of anything planned, but I wondered if there are any NHSE colleagues that wanted to talk to the type of qualitative work that's in train for the future.
They're all going to look for me, I think, now, aren't they, Jenny? So I'm Jo, for those who don't know me. I'm Insight and Feedback Lead in NHS England. I lead on the qualitative data and analysis. So we do have plans to do analysis of those experiences with rare and less common cancers, and recognition that the statistical information for those groups can be suppressed often and can be quite difficult to work with. So we're prioritised and have focused in on those groups. So that work is in early stages. I can't tell you today when it'll be ready to share. But yes, we're working with Cancer 52 on that project as part of our advisory group, and yeah, welcome any input as to how that's going to be most useful.
Thank you for asking us to speak today. We're going to talk about our Let's Talk Cancer initiative, which is based on these three outputs. This is what we're going to talk about. Thank you. So this project dates back to, started back in 2019. You can see on the screen some of our scores from the 2019 patient survey, and you can also see that they're quite poor. These three questions in particular drove some of the work that we've subsequently done with our Let's Talk Cancer project. Next slide. Thanks. So what we did is we thought about how we're going to manage these results. Every year when these results come out, we get asked, you know, what you're going to do, how are you going to, what's your plan, how are you going to improve this? So what we did was we looked at our patient comments, free text comments, and did quite a deep analysis of that and started to draw out themes which were coming through. And a lot of those focused around communication. The first thing we did after that was to talk to patients. So we, you can see a few of the patients here, and I recognise they're not a very ethnically diverse group at that time, but this is just a few of them. And we brought the patients in and listened to them some more, and wanted to really co-produce our project with them. Next slide. Next slide. Thanks. So what we did is we created this Let's Talk Cancer campaign, and the aim of it really was to reinforce simple steps for communicating effectively with patients. So each of these points broadly targets all staff who interact with cancer patients and families and carers every day, and highlight 6 simple everyday actions that staff can do, which will hopefully have a positive impact on the patient experience. And what we actually did was co-designed the wording for these 6 points with the patients. So we started off with how we thought this would look was that patients would ask us, can you, or will you? But actually, having co-produced this with the patients, they felt it was better coming the other way round, so that we're telling patients what we're going to do. We will, and we can, and we are. So all of these points up here are actually very broad, and although we're talking specifically about cancer, I think you can recognise that actually all of those points are very relevant for any patient with any diagnosis beyond cancer. Next slide, please. So alongside those 6 points, we created these are just lanyards that staff can wear around the hospital, attached to their name badges, which again reinforce the 6 points. Go to the next slide. Next slide. Okay, so we did a big launch with this project back in 2020. So these were our then chief executives at the time. We did a big project on Freenet, our internal server, every day, talking about these points, talking about, you said we did every day focusing on one of these key principles. We launched through, we had various kind of pop-ups in the hospital, in the canteen near the main entrance, and we actually had a big cancer away day for the multidisciplinary teams, so an external venue. So again, we launched at that event as well. Next slide. Next slide, please, AJ.
I've moved it on mine. It should be saying output 2, top 10 tips.
Okay, sorry, it's just not moved on for us, but if everyone else can see output 2, 10 top tips.
Hang on a moment, I'll stop and restart. So, how about now?
Lovely, thank you so much. So Kerry's explained to you the 6 principles that we developed for staff to help them model best practice communications and behaviours. So in parallel to that, deliberately, specifically for our patients, we launched these 10 top tips. And 10 top tips is a flyer that goes out to all newly diagnosed cancer patients in their newly diagnosed information pack. And it's also been on display throughout the clinical areas that cancer patients frequently visit, and that's across all our sites. So we're currently a 4-site trust. So these 10 top tips had a lot of visibility around our physical estate here at the hospital, and we made sure that as well as including it in the pack, the CNS or the cancer support worker who was talking through that pack of information that goes to the newly diagnosed patients specifically highlighted these 10 top tips to them. Next slide, please, AJ. As Kerry said, because we actually started this initiative in 2020 and then carried it throughout COVID, and I know earlier in our breakout room, we heard a lot about the changes that COVID has brought, which are substantial and lasting. So this year we refreshed our 10 top tips to reflect more accurately a post-COVID era where we're delivering our cancer services in that hybrid digital face-to-face model. Next slide, please, AJ. And finally, we have the 3rd output, which is our interactive online training module, which we created last year. And we created this really as the culmination of the previous 2 outputs of the 6 principles of good communications and behaviours and the patient-facing 10 top tips. And this really was designed for any staff in the hospital that interact with cancer. So Kerry and I really weren't thinking of people in roles such as cancer clinical nurse specialists or members of the MDT who regularly do their advanced communication skills. We were thinking more of ward staff who aren't working on a cancer-specific ward. So ward staff on our general medical wards, our acute medicine wards, our surgical wards, who for them, working with cancer patients and communicating with cancer patients isn't so much their bread and butter. And we also had in mind various admin and clerical roles. We wanted everyone from receptionists to porters to be able to access this training. Next slide, please. And it's actually a very quick bite-sized training.
in total, it should take people no more than 10 to 15 minutes. And technology permitting, we are going to give you a preview of the module. So I'm skipping out a bit about the module just to let you know that at the end of the module, all the learners who successfully complete, next slide please, do get this downloadable summary, which they can then keep to reinforce their learning, to refer back to. And it just gives examples of why Kerry and I feel so strongly that all staff across the whole of our trust should be very mindful every day of these 6 principles. Next slide, please. A lot of which, you know, as Kerry said, they're common sense, they're not rocket science, but they are things that we find that obviously when our staff are super busy and they have so many patients to see and not enough time, these are some of the things that can actually slip, and that happens to the best of us despite the best of intentions. So next slide please, and I will hand back over to Kerry.
Thank you. So I'm just going to talk a bit about the impact to date. So internally we've got over 1,000 learners now that have completed this module. We did have some issues with launching it on our server, which caused a delay, but to date we've got over 1,000. Our aim really is that this is adopted by the trust as mandatory training, and we're kind of we are going through that process at the moment, which is quite long, and we're having it to work quite hard to get that as our mandatory training. We're also embedding it into the communications strategy for the trust, which I think if we can get that embedded as part of that, it will then be easier to have as part of our mandatory training. The module is part of the induction programme now for nurses, currently not for clinicians. We've created a generic version of the module. So although our module shows some of the royal-free NCPES results, we've removed those and created a more generic version so that other people could use the module. And to date, we've got 6 other trusts that have confirmed that they've started to use the module. So we're very happy to share this module. There's no cost for using the module, but we do ask that trusts sign something to try and keep a record of the footprint. We're really just trying to gauge how many people are actually accessing the module across the country. And we've also had some conversations with the team from Gateway C that are also currently reviewing our module with a view to having it on their survey so that on their server so that primary care can also access this. Next slide, please.
So just very briefly, we wanted to share with you some of the challenges that we faced with our Let's Talk Cancer initiatives, and also what we feel were the keys to our success. So obviously, this is not going to be a surprise to anyone. Time within job plans. Of course, it's difficult to carve out time for improvement, quality improvement initiatives, and cancer patient improvement initiatives when we already have a really full, busy clinical workload. The pandemic also waylaid some of our engagement plans. So Kerry showed you earlier the photograph of the few user representatives that we did actually manage to sit down with face to face. Obviously, because of the pandemic and restrictions on who was able to physically enter our hospital buildings and pass through the screening by trust security guards, we had to conduct a lot of our patient engagement and patient co-production activities online. And of course, that raised the issue of bias and digital exclusion because patients who don't have access to the internet and patients who needed things like interpreters or adjustments in order to participate were excluded. One of the things that we feel helped us despite those challenges was that from day one we had exec level buy-in. Kerry showed you earlier the photos of the trust group chief exec and trust site chief exec attending our launches. And we feel that having that kind of profile for our improvement initiatives really helped us to engage staff groups who may have initially been a little bit sceptical of what we were trying to achieve, or a little bit reluctant to climb on board our Let's Talk Cancer train. We also had Royal Free Charity funding, and when we show you the actual interactive module, you'll see why the funding was necessary. Because we were privileged enough to have funding from the Royal Free Charity, that's one of the reasons why we're able to offer our online learning module to other trusts for free, because the funding has been taken care of. And we've already mentioned that early patient co-production was absolutely crucial, even crafting the wording, crafting some of the nuances of the key messages. And Kerry and I were really pleased that last September we achieved national recognition of all our work with a Patient Experience Network Award. So next slide, please, AJ. And the next one. So just finally, what are the next steps for us? So, you know, we're really pleased with what we've achieved so far for this, and the charity are obviously very pleased, and we've been able to apply and be guaranteed additional funding now from the Royal Free Charity for further work. So we're using this brand of Let's Talk Cancer to create additional patient information videos now pre-treatment for Let's Talk Chemotherapy. So we're working with the same small company actually that we've worked with to do this. So we've done the script for that now, and it's actually being created. So we're really excited about that. And also the work, the specifically the module, the communications module, has been nominated for a digital award, and we've got that ceremony coming up in September. So I hope that the team we worked with do really well for that. And we're continuing to engage with new stakeholders, and I've mentioned primary care, but I'm really hopeful that if we can get this module onto Gateway C, that will you know, provide opportunity for thousands of others to engage with the module. So I think that's the end, and we're hoping now that we can show you the module. So normally this wouldn't be done in front of a group of people. You'd do it individually in front of a computer. So let's hope that that's going to work.
Perfect. So let me just get my screen up. Bear with me 1 minute. And let's fingers crossed that this works in the test. So hopefully everybody can see that. I'm just going to play now.
I'm so cross. Who on earth do these hospital people think they are? Barely acknowledging my existence, talking over me, giving me no time to think. You'd think they'd have just a little bit of understanding of what I'm going through. They were telling me about my cancer test results, for goodness sakes. I wish I could have taken someone with me. What a disappointing, miserable nightmare. I feel traumatized. I can't even remember what I have to do next. Have they just written me off already? I don't think I can do this if it's like that all the way through. Oh, where are my manners? I'm just as bad as them. I'm Ugochi. Ugochi no Wachukweyu, by the way.
Perfect. So hopefully that played okay for everybody. And thank you very much, Kerry and Azmina. I was wondering if anyone had any questions. I'm just going to have a little look in the chat as well, but do feel free to put hands up. I'm seeing a lot of kind of people saying really excellent piece of work. People seem really excited. People also seem really excited to kind of get in touch as well about kind of sharing that. But any kind of questions at all? Anna, you've got your hand up. Oh, Anna, I think you're on mute. Okay. I'll go to Sarah because I think Anna is on mute. Sarah, I saw you made a comment and you might have a question as well.
Yeah, I do. Sorry, Anna. I'll just just to say, absolutely brilliant. I mean, you know, this is why I do what I do. I mean, this is what it's about. So, oh wow, the passion is there, everything fantastic. Can I just ask, and I may have missed it because there was so much going on and so quickly, how are you checking back to see that what the messages you're putting out are actually landing with patients now and their families? Because, you know, I've certainly been part of a lot of initiatives and, you know, they get all the big backing and everything and, you know, it's all guns blazing and everything. And then a year later, you know, it's gone and you wonder what that was all about. So sorry, I'm going on a bit, but can you just say how you're actually ensuring, as best you can with all the challenges, that what you set up is still happening?
Yeah, so in terms of specifically with the module, we're obviously tracking the footprint of that. And then we're using the yearly NCPES results to kind of look at our scores. We're hoping for direct improvements. Now, I know we all have to now recognise that the questions have slightly changed and may not be directly comparable, but that is ultimately what we're using. We're using the national results, and then internally, I guess it's smaller teams do tend to, you know, do similar audits specifically with their tumour type. So if we roughly compare for this year, we have seen an increase. I would expect and hope for a bigger increase next year.
Fantastic. Can I just ask one other very quick question? And again, forgive me because so much was going on. Is that online? Did I hear correctly? Is that just for nurses or something? No, because there was something where I thought medical, like doctors and everything, weren't doing. And if that was the case, I was going to say, why is it not accessible for all? Because everybody is so needing of this sort of input.
I think it's that we've got it onto the nurses induction, but not the medical induction yet. But ultimately, if we get it onto the mandatory training, it will just be everybody. And we're also looking at the non-clinical staff because I think it's would be really great for them as well.
Yeah, and actually at our trust, it's been really popular with pharmacists and also with reception staff. And of course, reception, the first people in the hospital that every cancer patient meets. So we were really pleased to have such good engagement levels from admin staff groups as well.
But this will support every patient, whether they're cancer patients or whatever, throughout your organisation. Brilliant. And now I'll shut up.
Thank you, Sarah. And actually, your praise and endorsement means more to us than like any award. So thank you so much for saying those very kind things.
Thank you. Yeah, thank you both for that. Anna, I will go to you. It looks like you've managed to unmute yourself.
Thank you very much. I just wanted to say, so I'm Anna Rarity, Cancer Experience of Care Programme Manager in the National Cancer Programme at NHS England, and I had the pleasure of meeting Azmina and Kerry at the Patient Experience Network Awards when they won the Cancer Experience of Care Award prize. But I've also had the pleasure of watching much more of the training module, and just the excerpt that we saw just there. I just wondered if you could just give in a couple of sentences just more of an understanding of the different, you basically use different perspectives, don't you, of an appointment having gone well. What does an appointment look like? And I just think perhaps just seeing that one excerpt doesn't really properly describe it in some ways, and I just wondered if you could balance it up. And also just to say that in the chat, you know, so many people are asking for your details and want to be in touch with you. And one of the brilliant aspects of your piece of work was that it's so transferable, and I know how keen you are to transfer it and share. So just congratulations again. Thank you.
Thank you, Anna. And actually, the pleasure was all ours. And we're grateful to you and your colleagues for connecting us with so many other potential stakeholders who are keen to embrace Let's Talk Cancer. And yes, it's a pity that due to time, Claire wasn't able to show you the next clip in the series, but essentially it runs through our fictional triple negative breast cancer patient, Ugochi's journey through her first clinic appointment, during which her oncologist was not necessarily exhibiting all of the 6 best practice behaviours due to time constraints. And then we end with much more positive scenarios where the patient is felt, the patient is made to feel heard and listened to and valued, simply through the application of the 6 principles that we've mentioned of, always involve, ask, confirm, support, etc. And we are very happy to share the generic version of the module. So please do reach out either through the chat in this Microsoft Teams call or separately through email. So thank you so much.
So I've had a privilege today of sitting and listening to all of this fantastic work that's been happening, and being able to reflect on some themes. And I think we couldn't have had a better start, Sarah, than your introduction, which hopefully we've recorded it. I don't know if we have, but that is an expression of why patient experience matters, and how experience links to other dimensions of quality, in safety and outcomes. We couldn't have wished for a better start. So thank you very much for that. And I think we need to remember that it's not easy to relive some of the experiences that we're hearing about today, but we have this year heard from 61,268 people about those experiences, and we've got a real duty to listen to those voices and to bring about change. And what I've heard very clearly is that people really feel that responsibility, and are bringing about in what you do. I think that there were 3 things, Sarah, that really, I mean, a number of things struck me from what you said, but there's 3 I wanted to draw on. I think one that you were talking about, this is about being about human relationships, and it absolutely is a bit about being human relationships, but there is always a danger in the way that we work, that we can make it feel transactional, or we can make it feel like a parent-child relationship in terms of receiving care, and it's easier to do that when people are busy, and they don't think about things from the individual patient or carer's perspective. So it was really good to see that being recognised in a range of different ways, including in the case study we just heard from the Royal Free, and the recognition that if we get things right, then we can move people from a period where anxiety might feel overwhelming into a place where people might feel that they are being treated as equals, that they are valued for what they bring to the conversation, and that we are seeing people as partners. And I think it's particularly important. One of the things that's always struck me about cancer care is when you talk to an individual clinician, they've almost never seen the entire journey that someone with cancer goes on, unless they've been a patient themselves, and that can be quite an eye-opening experience. And so the fact that the patient is there to help and sustain the continuity of care, and to make sure that the care plan is taken forward, I think is really important. So I think that as ever with these results, there are some dangers to us, particularly as everybody is busier in the service. Then there are some warnings about slipping back into transactional mode, not introducing ourselves, or people being too busy to offer help when help is asked, but also some very promising signs. So I was pleased to see that levels of involvement were holding up. They're not doing that in other areas of healthcare at the moment, so that was good to see, and some significant improvements in the involvement of family, I think, was also very welcome. So some promising signs there, but just a reminder to us that, as you know, and as you shared experiences, there is a danger when people are busy, that it becomes more transactional, and we have to watch against that. A second thing, Sarah, that you said, which really struck me, was that it's the right thing to do to ask, it's the right thing to do to speak up, but it can be hard to do. And I think sometimes we forget when we're working in the service that it can be hard for people to do that. And on many occasions, I've talked to people who say that people look fine on the outside, they look like they've taken information in and they've taken it in their stride, but actually that's not how they're feeling inside, and we do have to ask, and we do have to check with people. So I think it's very important about how we set the context, as you were saying, Sarah, to encourage people to ask questions. And again, some mixed signs here. So that people saying that that they weren't always given enough time to express their fears and worries, and we do need to make sure we take that extra moment to check with people, but also some promising signs in relation to care planning and how care planning was working, and really adjusting the care plans to take into account what we're hearing from people. And I was interested in my breakout group about some of the group conversations that people have been invited to have. So yeah, if you're part of a group, you might find other people are asking questions that you really wanted to ask, but you haven't yet asked, and that was an interest. I think we're finding that in a number of different areas around healthcare. I think we heard it in maternity too. So that was a very interesting thing to hear. I think when we're talking about collective voice, it's obviously really important to think about who is in the room, who we're hearing from and who we're not hearing from. And in my breakout group, there was quite a conversation about demographics of the survey, groups of people we're more likely to hear from, less likely to. It's still quite common for me when I go and meet a group of patients involved in cancer care at a hospital that they're all white or very nearly all white. And I think it's just recognition that we need to use a mixed set of methods to engage with people. There will be people for whom we won't, whatever we do to adjust the survey, and we do a lot of work to adjust the survey, that they won't be responding in as strong a number. So we need to be mixing the survey results with lived experience partners, with targeted engagement work in different kind of ways, to make sure we get a rounded picture. But I think one question is always to ask is who is not in the room when you're having these conversations. And then the third thing you said, Sarah, which is around it's just the way things are. I didn't get that impression from anybody on the call today. Everybody's making progress, which is great, but I think we do have to acknowledge that sometimes it feels difficult. And some things do feel intractable, and they can particularly feel intractable if they're about administrative systems. They can feel intractable if they're about supply chains. And I think the lesson there is that persistence does work, and progress can be made. And sometimes it's easier when you collaborate. And one of the beauties of an occasion like this is that people learn from each other and borrow from each other. As well as identifying things that maybe at a national level we need to help along. And quality improvement is an art as well as a science, isn't it? So I think while I was hearing these examples of both, that working with people, really building on people's insights, but also really looking at what does the data tell you, where does it drive you to focus. So I think that just final thoughts really for me, the importance of understanding variation, that overall results are still very good in terms of people's experiences, but some people's experiences are continuing to be better than others. It was really good to see the focus on mental health and learning disability in the going forward. That's something I think we've missed, but we already know, don't we, that some ethnic groups still continue to get a poorer experience. And some of the things that we do underscore that. So if it's harder to get a wig if you're from a particular ethnic group than it is for others, you will feel about the service in a different way than we would want you to feel. So variation is important, I think, and obviously when you've got the data, talking and discussing it with patients and service users and carers is crucial. So they will understand what matters, they will understand what the priorities are, they will understand some of the things that can be done. And quite often we find that when we're talking to service users, that their suggestions can be actually more practical and cheaper to implement than the kind of things that a staff team might suggest that we do. So just really lock in the value from that. And the final thought, because there's some great stories being discussed here, we'd really like to know about them and share them. It's really encouraging, I think, that to hear from people who've tackled a problem and made progress. Sometimes in healthcare we focus too much on the deficits, about what's not working, and actually the thing that really works in leading change is to focus on the positives and to inspire people about doing better. So please do share with us what you're doing and what's working, and understand that there may be some funding from NHS in to support development of case studies if you've got a good improvement case study that you want to share with us. So please do let us know. But I've just really enjoyed listening to the experience. I wish I'd been able to be in all of the groups. Unfortunately, that wasn't physically possible, but it was great to get a bit of a summary from it. But thanks so much for all that you do.